Welcome to the Dallas Area Gerontological Society 2020 Annual Fall Forum, the year everything changed. Peggy Pappert, our forum chair, will introduce our next speaker for a Dementia 2020 update. Thank you, Peggy.
Welcome back from the break, everyone. Hope you got to see some people in the networking rooms. I am going to introduce our next speaker. Dr. Heidi Rossetti, a PhD, is a board-certified neuropsychologist who got her doctorate in clinical psychology at UT Southwestern, where she served as the chief resident. She holds a master's in science degree in rehab counseling psychology from UT Southwestern as well. Upon joining the UT Southwestern faculty in 2012, her departmental activities included neuropsychological cognitive evaluation of persons with known suspected neurological disorders. Dr. Rossetti's clinical experience is in the area of neuropsychological assessment, with particular interest in differential diagnosis of dementia, and has expertise in sports concussion. Let us give Dr. Rossetti, with her 2020 update on dementia, a big welcome. Thank you.
Thank you, Kathleen. I appreciate that. I'm excited to be here this morning with everybody to talk about something that I know is of importance to all of us. And my goals for today are to sort of just do a very kind of brief brush up on where we are in terms of the epidemiology of dementia, and then shift into kind of current approaches to diagnosis, and then into giving you an update on where we are in terms of different types of treatments and interventions. And then I'd like to end on sort of discussing the situation in which we all find ourselves, which is the overlay of COVID-19. So I usually like to start out talks or lectures with some kind of little quiz, little brain exercise to get us going. So I hope and I think that y'all can respond on the chat in Zoom. And so please feel free to drop your guesses or answers there, and we can get a sense of what everyone's thinking. No pressure as we move along. So, and Kathleen, let me know if this is or isn't working, since I can't see that. Okay. So true or false, if one of your parents had Alzheimer's, you'll likely get it too.
So we have a couple of responses, and so far they're all false. False, 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 false.
Exactly right. False. This is something we'll talk about today. But essentially, any of us walking around out there have about a 10% chance of developing Alzheimer's disease, and if we have a family member, that increases our risk to about 20%. So it does increase risk, but not a dictating amount. True or false? Alzheimer's disease costs more to society than cancer. How's that looking?
So far we have true, 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 true.
You guys are on point today. Yes, exponentially more expensive to our society than cancer. And which of the following increases our risk of Alzheimer's disease? Is it old age, exposure to aluminum, or aspartame exposure?
This one's going to take a little longer. Okay, so we have old age, aspartame, old age, aluminum, old age, B aluminum, old age, aluminum, old age, old age.
So a little bit of a mix on this one, but yes, the answer here is A. The other two were considered at some point many years ago and have been debunked, but still kind of have a hold out there in the public. When true or false, when patients have a dementia, their doctor always informs them of their diagnosis.
False, 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 false.
Oh, so false. Yes, we'll touch on that as well. And true or false, lastly, in many cases, it's possible to prevent dementia or to delay the onset.
True, true, false, true, 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 true.
Yes, thankfully this is true, and we'll talk about that today as well. So thank you for that. Shifting into a figure that probably you have seen some version of this before, but essentially what is the scope of the challenge we're dealing with? And this is essentially showing you, the projected number of individuals in the United States with Alzheimer's disease up to the year 2050. And so at the moment, in 2020, we're around the 6 million mark. And depending on the study you look at, the projections are around 14 to 16 million in 30 years. As most of us know, it is a leading cause of death. Last year's number put it around the 6th leading cause of death. And cancer and heart disease take more lives, but Alzheimer's disease, as we've alluded to, is much more costly, upwards of $2 billion a year. And something else to note about these types of figures is that they're almost always an underestimate for a number of reasons. And one is that upwards of 50% of dementia cases are missed entirely in primary care practice. And so they're unaware of their diagnosis. And if they have that diagnosis, many of them do not know that their doctor thinks they have dementia or is treating them for dementia. And this is shown in this figure here. This is Medicare data, essentially just telling us what, if you have a certain disorder, like let's say cancer or Parkinson's disease or something like that, how often is the doctor disclosing that to their patient? And you can essentially see up here at the lowest mark is Alzheimer's disease. Less than half of the time are they being told that by their doctor. And if they have another type of dementia, it's even less likely that the doctor will inform you. And this is for a number of reasons that could be its own talk, really. But the point being that when we look at numbers and expectations, that these are likely way underestimated. Now, I think a lot of you probably already know that dementia is an umbrella term, right? And that underneath that umbrella are many different, types or causes of dementia. And when I talk with patients, I'll tell them, okay, well, it's like if we said cancer, right? The next question would be, well, what kind of cancer, right? And dementia is the same. If someone says you have dementia, really the next question should be, what type do I have? What's causing my dementia? And there are many, many potential etiologies or causes of this. Just a few of them are up here on the screen for you. What I would like to do this morning is just to focus on the top 3 most common forms of dementia. And then as we move along, you'll hear me reference Alzheimer's disease the most, because that takes the lion's share of the number of cases and the lion's share, therefore, of the research, right? But in general, there are 3 kind of most common types of dementia, and the first and foremost being AD. And this is kind of just a snapshot. Can you guys see my cursor, by the way, when I move it?
Yes, we can.
You can. Okay, great. Thank you. So this is just a snapshot here of a kind of that basic epidemiology of these forms. And you can see here that, as we already alluded to, Alzheimer's disease is much more prevalent than the other 2 most common forms. And you can also see a general breakdown of, sex preference for the disorder, what age it's likely to begin, and what the underlying cause or pathology theory is. And we'll talk about that later this morning, and so forth. Now, really kind of one other thing that should be said is that in addition to those types of dementia, it's very common for patients to have what we refer to as a mixed dementia. And this means that they have Alzheimer's disease happening along with the misfortune of some other form happening as well. Most often it's a mixture of Alzheimer's and Lewy body dementia, or Alzheimer's and vascular dementia in the United States. That's a common mix. However, when you break this down by age group, regardless of the mixing of diseases, Alzheimer's, you can see here in the blue bar, is far and away the most common one, again, across the age range. So as a whole, for adults out in the United States, dementia is occurring at about a 1 to 2% prevalence rate. And then once you kick past your 8th decade of life into your 80s, the risk goes from 1 to 2 to 30%. So in general, most studies will suggest that once you're over the age of 85, that 1 in 3 of those individuals will meet criteria, at least, for Alzheimer's disease. I want to touch very briefly on what the going thought is about the causes of these forms of dementia. And classic, Alzheimer's disease involves neuronal loss and these characteristic changes happening that involve the deposition of amyloid in the form of plaques and the buildup of tau in the form of what we call a tangle, or a neurofibrillary tangle. And you can sort of see these depicted here. And what I always like to note is that amyloid and tau are normal, necessary substances in the brain. We all have them. We all need amyloid and tau. The issue is that it begins to misbehave, right? And things start to happen with those, right? With these proteins that should not be happening, and they begin to clump together, cluster together, to twist in on themselves, and that prevents neurons from communicating with each other and sharing, nutrients that the cells need, right? And this is kind of thought to be an underpinning of Alzheimer's. Now, it is possible that these kind of famous plaques and tangles are not really the root cause of Alzheimer's. That's debated in the literature. However, regardless of that, it is these two things that make AD its own unique form of dementia. Probably the most significant update in the field of dementia really is in the area of neuroimaging, and there has been some incredible advances in the last decade or so on how we scan the brain. And we can, many people are familiar with the fact that you can have an amyloid scan, which is a form of a PET scan, where you can actually see the buildup or the presence of amyloid in the brain. And that is what this first row is showing us. This is an amyloid scan, PET scan. And as you move along here from left to right, it goes from normal to an abnormal brain with a lot of amyloid in it. And that is now, it's approved for clinical use, and it is, you see it more routinely now than we have ever done. Over and above that, its kind of sister problem, tau, has been basically invisible to us, to everyone really except the pathologist at autopsy. It's never been able to be seen in life until the advancement of tau imaging. So now, just like with amyloid, we can do a PET scan of a different form and see tau building up in the brain. And this has been a really exciting advance in the last few years. So one thing to note here is that you can see here that these scans are labeled CN, which means cognitively normal. These are patients who do not have dementia, right? But you can see here that this person seems to have some stuff going on, right? There's some amyloid here, there's some tau here, but this person does not have dementia. So this is where a word of caution is warranted, right? Because about a third of quote unquote positive scans, meaning there is amyloid in the brain, are in patients who are entirely asymptomatic. And so we still have a lot to learn about the technique and what it means and so forth. And it's not a trivial thing. And so one case example I'll offer you for this is a patient of mine who participated in a very large, well-known clinical trial related to amyloid scans. And he was told at the end of his participation in the study, or at least what he heard, in his mind was that he had a positive amyloid scan and you have Alzheimer's disease, right? And he was very high functioning. He is high functioning, very healthy, but had a history of some depression in his past. And very out of character for him, he attempted suicide shortly after this information was given to him. I have seen him now for 6 years, every year for monitoring. And I'll tell you, his cognitive ability is still well above peers of his age, and he shows absolutely no signs or symptoms of developing Alzheimer's disease. And so it's something that needs to be used by individuals who are equipped to interpret it and equipped to communicate the findings and its limitations appropriately. Now, moving briefly to Lewy body dementia, or dementia with Lewy bodies, this is the second most common form of dementia. And it comprises roughly 30% of cases. And in contrast to the amyloid and the tau that I mentioned with Alzheimer's, in Lewy body, we have a different culprit, right? We have another protein that's misbehaving, but this one is called alpha-synuclein. And you can see here, these clusters are called Lewy bodies after the gentleman who discovered it. So that's kind of the underlying cause there. There are certain features or symptoms that really, if they're occurring early in someone's illness, should raise the red flag for something different than Alzheimer's disease and potentially a Lewy body disease. And you may look at these here and say, okay, cognitive ups and downs, hallucinations, tremor, some dream enactment, and think, well, I see that in my patients with Alzheimer's too. And that is certainly can happen. The distinction diagnostically is when is it happening. So in patients with Alzheimer's disease, these types of things can happen as the disease advances, but it's not typical to see them early on in the first few years. And if that is the case, then really we should be entertaining a potential Lewy body diagnosis. It is an interesting set of symptoms. These cognitive fluctuations, really, the way I describe it to families or patients when I'm asking about it is, it's like looking at a blue sky and all of a sudden clouds come across, right? And they sort of move across and then they go away again. You know, it's kind of like clouding confusion that comes and goes from maybe a period of hours to days. The visual hallucinations are also interesting and incredibly common. The majority of patients with Lewy body will have some hallucinations. And interestingly, they tend to be of the same flavor. So they tend to be children in the home, small animals in the home. They don't tend to be upsetting or distressing by and large. Often it can begin in other ways with what we call illusions or illusory experiences that aren't really a hallucination. So for example, a patient saying, well, it's so weird, you know, I went on a walk and I see a stick and just for a moment, it looks like a snake and I have to look again and I have to look again before I realize that that's not a snake, it's a stick, right? So things like that could be suggestive. And anytime a patient begins to develop cognitive problems along with motor changes like tremor, stiffness, things that look like Parkinson's disease but are not Parkinson's disease, that would be, again, a red flag there, as would be acting out our dreams in a state of sleep where we really ought to be still. And the PET scan that I mentioned earlier, those can be used to help differentiate if something is Alzheimer's disease or Lewy body disease in cases where there's a lack of clarity. The third and final form that I want to touch on today is FTD, or frontotemporal dementia. This is a really interesting and complex cluster of problems and disorders, and I'm not going to go into that today, but I just want to note that what you have here are basically two types of FTD. One is the behavioral form, behavioral variant, and the others are language forms. So they're really quite distinct from each other. But the behavioral variant is the most common form of FTD. Now, you'll notice here that we've gone way down here. So FTD is about 4% of dementia cases. So if you think back, Alzheimer's disease was somewhere around 60 to 80% of dementia cases. So this is not that common, but it is the third ranked. And what's happening here is, again, tau is involved in FTD, but in a different way than Alzheimer's disease. And the classic heralding features here are, as the name might suggest to you with behavior, is really pretty dramatic changes in personality and social comportment and how they're conducting themselves in ways that are very vastly out of character or inappropriate for society. And it can be accompanied by other emotional changes too, like kind of a loss of empathy, you know, a patient whose child dies and have little to no reaction to that, don't understand why their spouse is upset. You know, that can also be a feature of a behavioral variant FTD. So all of these dementias are still a clinical diagnosis, right? We don't have a blood test for any of them, that sort of thing. So what we'll do in terms of approaching this clinically is to take stock of those features that I've outlined for you, and they're sort of summarized here in this table, and sort of try to deduce the pattern and what seems more likely here. And another thing is that patients will often have sophisticated neurocognitive exam, which you can see here. This is looking at different cognitive domains, so intellectual functioning, attention, memory, so forth. And you can see with these lines that these different types of dementia are pretty different from each other. And so neuropsych testing can help add and kind of refine diagnostic accuracy. Now, what all of these have in common is this one here, which is they have an insidious onset, which means they do not happen overnight, as we know, and therefore, by definition, they all have some phase that is preclinical or mild, right? And that is really where the emphasis in the field is the mild stage. Now, overall, at least from our perspective at Southwestern or in most Alzheimer's disease research centers, is this would be considered a gold standard current workup for dementia. And, it should include anything from a detailed exam to potentially having a scan of some kind, blood tests to rule out other factors, of course, and neuropsych testing. Sometimes you'll get a spinal tap done to look at some cerebrospinal fluid if the diagnosis is unclear, that sort of thing. So this is the typical classic gold standard workup at this point. Now, when this type of comprehensive evaluation is conducted, the accuracy of a clinical diagnosis is around roughly 90% accuracy, even though we still need an autopsy to get to that 100% mark, but you can get pretty darn close. And for example, in our ADC, our accuracy rates are around 95% accuracy. So when we think about aging and dementia, of course, we're always thinking about this as a continuum, right? And the bulk of us are going to experience normal aging, but not everybody, of course. And so there's this progression or continuum over time and with age. And a lot of my work as a neuropsychologist is distinguishing sort of where is somebody on this continuum. And also what I wanted to show here in this notion of a continuum for you is that when you're moving on this lower figure from being normal and normal ager into MCI, mild cognitive impairment, or dementia, different things are happening at different times, right? So this orange line is when we think amyloid is starting to build up, right? That's happening well before someone actually shows this purple line here, which is actually a memory problem. So it's way before. And so this is where the action is in this MCI area, because, it takes time for these things to develop into a problem. And essentially this is, arguably the kind of biggest unmet need in modern medicine is a need for a treatment for these set of conditions. And the early detection is now considered a worldwide scientific priority. And part of the reason for that is because detection goes hand in hand with prevention, right? This is critical, right? Patients need to have a quick, accurate diagnosis. And we all may know some reasons why, right? Sometimes you cannot access certain resources in the community unless you have a diagnosis of dementia, right? You can't enroll in one of the kind of cutting edge research studies unless you have an appropriate diagnosis, for example. So it's important for access. And then from a practical standpoint, it gives patients and families time to plan. It gives empowers people to know what's going on with them, A, and B, to take an active role in their care and planning when they're cognitively able to do so. And providing intervention at the early stage is really what's going to be needed in any of these diseases because a sick cell is easier, of course, to treat than a cell that has died, right? And that's what we need for early detection. And it's not trivial, right? The notion of delaying onset, if we were to just hold off someone's dementia onset for 12 months, that collectively translates to 9 million fewer cases in this country in that year. And you can see how impactful that would be for us as a society. I've kind of been alluding to this notion of early detection and a preclinical stage. In the field, we refer to this as MCI, or mild cognitive impairment, and I will explain to patients as it kind of being a border zone or stage, if you will, between normal aging and dementia. And it increases someone's risk for progressing to a dementia over time, although not everybody eventually does. But one thing that we are doing in the field now is we are actually categorizing and subtyping the type of MCI someone is showing. And the reason for that is, again, this is not true for every individual, but in studies we're seeing that the type of mild cognitive impairment you have early on seems to predict what type of dementia you may be at risk for. So for example, if someone has mild cognitive changes that are mostly in the area of memory, we call that amnestic MCI, and they are much more likely to convert to an Alzheimer's disease. Whereas, for example, if someone meets criteria for mild cognitive impairment, this preclinical stage, but they don't have a memory problem, let's say they have a language problem with speech, that is more likely, for example, to go to an FTD. All right, so we can, it's important for kind of categorizing and giving people a prognosis that's more and more accurate over time. So I want to shift from kind of the approach to diagnosis to what we know about intervention and kind of what's been interesting and new in this area. Of course, you know, it has to be said that unfortunately, we're not talking about today some new treatment, right, that stops or slows the disease. We don't have it yet. We still do not. That said, we do have a lot of work being done in the area of treatment that is either behavioral, meaning not drug related, and pharmacological. And I want to just start by touching on this more sort of lifestyle type of interventions. Because in the last 5 to 10 years or so, we've sort of coalesced with multiple studies around the idea that roughly 1/3 of dementia cases may in fact be due to a modifiable factor. And you'll see the ones that have support for them in the research listed here. And you can see that they're quite common. So things like having high blood pressure or obesity, particularly abdominal obesity in middle age. All of these are risk factors that can contribute to the onset or flipping the switch for a dementia. And what's been exciting about this behavioral intervention side of things is that there's been a big movement towards a multidimensional strategy, right, which is to protect brain health and reduce the risk of dementia. And this multimodal approach is not new. It has been done very effectively in heart disease and in some cancers. And it may be just as powerful with dementia. One example is the FINGER study, which is out of Finland. And they basically did a 2-year combo, really intensive combo with patients who were at risk for dementia, with exercise, nutrition, cognitive stimulation, and so forth. And they were able to show that just reducing these risk factors by 10 to 20% translated to a significant reduction in Alzheimer's onset over that 2-year period. So Up to date, there has been no drug that has shown the effect size of the finger study. And so now it's being kind of worked on all over the world. And in the United States, our version of this is called the pointer study. So in terms of what has actual evidence in order to feel safe recommending it to patients, if this is worth your time, this is worth your effort in terms of intervening for dementia, it would be these things. And I will talk with patients a lot about this notion of kind of like the Holy Trinity, if you will, right? Exercise, physical exercise, mental exercise, and really social exercise, if you will. Staying active in those three regions all have a significant amount of support behind them for reducing or delaying onset, as do things like nutrition. For example, in general, diets that have a Mediterranean type of approach do have support, some support for them in improving brain health. All right, so what about pharmacology? Like, what is available? What's going on in this area? This is a table of the current FDA-approved medications for Alzheimer's disease, and they're often used in Lewy body, et cetera. This list probably looks really familiar to you. It has not changed since 2003. There's just been really no action here. So it's the same kind of good old standbys, you know, Aricept or the donepezil, Namenda, that kind of thing. And the philosophy behind them is, you know, that they temporarily sort of boost the availability of certain neurotransmitters like acetylcholine, which is important for memory. They make more of that available to the brain and can therefore sort of hold things steady for steadier for a period of time. But they don't actually address the underlying disease process itself. So why is this area so challenging? I'm sure you have some thoughts, but maybe in the chat you can put out a couple of things that you think maybe are obstacles to finding treatment for Alzheimer's disease or dementia. Why is this so hard? And while you're thinking about that or typing it out, I'll give you this for food for thought. There are currently across the entire world 170 drugs being worked on for Alzheimer's disease, okay? Now, this is in comparison to almost 7,000 going on worldwide for cancer. So this is right out of the gate one of those big obstacles. But there are others. Any that come to mind for anybody?
So we have some comments in the chat.
Mm-hmm.
One is from Joan Gunther. She says informed consent is an issue.
Mm-hmm. Yes, this is true in terms of getting people admitted into studies. Mm-hmm.
Z. Clark says that I'm always amazed when MDs do not want to discuss this with clients.
Absolutely. Yeah, if you don't know that you have the problem, you're not likely to be participating in research for that problem, right? Absolutely. Good point.
Someone else says, my mom had dementia and we knew this, but the doctor did not diagnose her until the later stages.
Mm-hmm. Yes. So if all we're studying is patients who are way late in the disease, it's no wonder that a lot of the studies have failed. And that is why the shift has gone to milder and milder versions of the disorder.
We have two people, Vivian Armstrong and Martha Montgomery, who are both talking about how funding or money is always a challenge.
Yes, great point. And that's actually one I have here, which is that it's sort of here, which is this question of the cost of these studies. So I said earlier that dementia begins way before, decades before someone starts to have a problem. So therefore, that means that it takes time to prove that a drug works, right? That time means money. And so the trials are long, the trials are expensive, and they fail. And that's a lot of risk for an entity to take on. And that has unfortunately been the state of things, is failure after failure. Other challenges are that in contrast to, for example, heart disease or cancer, we don't know as much about the brain biology. Okay, I outlined some theories for you earlier, but we don't really know what to target as well. And then the other challenge that's not here on the slide is actually the brain itself gives us obstacles, right? One is known as the blood-brain barrier, which you may have heard of. And it is essentially a border of cells that protect our brain from substances in our body getting into the brain. And we need that and we want that, right? But that means that if you inject a drug or you take a drug, right, for your heart or your liver, it just gets in there, gets processed, and does what it needs to do. But if you take a pill or have an injection that's trying to get to the brain, it will have a double of the time getting through the blood-brain barrier. And that is another reason why these medications have to be really sophisticated. Okay. But what about what's in the pipeline? So I want to talk a little bit about the state of affairs, all right? So at the moment, there are 121 drugs that are in clinical trials. The vast majority of them are focused on disease, right? Actually addressing the biology of dementia, which is good. There are also trials focused on cognitive enhancement. Can you take a medication that helps your memory? And trials that are also very important, looking at how do you, for patients with more advanced dementia, treat their symptoms. So in the last 5 years, really the most important change or trend has been a shift away from a laser focus on amyloid. The amyloid hypothesis has dominated the field for decades, and I'll talk about that here in just a moment. But we're seeing new targets being put on the table, new investigations, which are really exciting and interesting. The other interesting development is this notion of a repurposed drug. And I don't know if this is something that y'all are familiar with or not, but this is done in all forms of medicine, is to take a medication that's already out there and being used and to see if it works for something else, right? And so this has the benefit, okay, of taking much less time because it's already been through safety trials, it's already been tested, and you save a lot of time and money that way. And at this moment, almost half of the drugs that are currently being looked at for Alzheimer's are in fact a repurposed drug. So medications that you probably know really well, or maybe even take, like metformin for diabetes or losartan, those are currently under investigation at the moment in a repurposed way. Now, one note about this is that repurposed drugs are not highly appealing to pharma, right? Because there's not a lot of money in a drug that's already available to people. But it's incredibly appealing for scientists in academic medical centers because it's much more affordable for them to study a substance that's already out there. And so the repurposed drug studies tend to be the domain of academic scientists more so than the big pharma companies. Okay, this is like, I know a lot to look at, okay, and I'm just gonna break it down for you. Essentially, I wanna highlight for you is this is a very cool kind of depiction of all of the studies currently in development for Alzheimer's disease. And the outer ring is what we call phase 1, okay? So these are things that are just getting looked at in animals, et cetera. Then the second ring is phase 2, and the middle is phase 3, which means a drug that's in phase 3 is close to prime time. If it passes phase 3, it could be approved for use. And so you can see it broken down that way. You can also see with the colors tell us what is being targeted. The red is saying this is a study that's looking at amyloid in one way or another, right? The blue is the tau studies, etc. Okay. And then down here, this is showing us, is the study being done in healthy people like you and I, or is it being done in patients who already have dementia? Or like this pentagon here, is it being done in patients who already have severe dementia? And you can see, hopefully, with our kind of quick visual scanning, that there's not many of those, right? There's not many studies at all really looking at advanced dementia at this point. This is showing essentially condensing that graph into phase 3. So this is all of phase 3. And that means that there are studies that have been going on a long time and they've made their way through the system, right? And you can see here that 60% of them are looking at the biology of the disease, right? What I want to show here for you is that dropping down below, we're looking at phase 2. This means that they're newer studies. They're not as far along as phase 3. And you can see a really big jump from 59% to 85% of studies in phase 2 are disease modifying, and there's been less studies focused on the symptoms or the cognitive enhancement. You can also see the percentage of studies that are amyloid focused is shifting. So 35% in phase 3 and only 20% in phase 2. So there's movement happening. There's some trends happening. Okay, so I want to talk a little bit about these treatment targets and where we are with them. The first target, as you're probably tired of me saying the word amyloid, is still incredibly important. And the approach here is essentially in immunotherapy, which is basically a common thing that we're all pretty well familiar with, right? It's a way of preventing or treating disease with a medication that stimulates an immune response, right? So it's sort of like a vaccine. You deliver an antibody. You deliver a molecule and it forms antibodies within the body, within your system, and then you can protect against that molecule, right? The difference with amyloid immunotherapy from a vaccine is that instead of just taking it once or twice, like we do with, MMR or whatever, all these other vaccines we have, is you have to, this is repeated over months and years when someone is relatively young to build up an immune response to Alzheimer's disease. So essentially, all of these, this is just a sampling of some studies going on focused on amyloid. All of them, they all have long, complicated names, and they all are some version of an antibody, okay? So the A4 trial is focused on solanezumab, and that is expected to finish up in a couple of years. The API is looking at crenezumab, and that's looking at patients who have a genetic form of Alzheimer's, which is only about 5% of Alzheimer's cases, also expected to give us results in the next couple of years. The DIAN network is looking at a different agent, and they just published their very first results this spring that were promising. They did reverse, this antibody showed a reversal in the amount of amyloid that was sort of deposited, sort of helped clear it out. And then this agent, which is so new, it doesn't really have a name yet, is now in phase 3, and it has kind of the really kind of holy grail finding, we'll see if it holds up, of reducing the amyloid and actually benefiting their cognitive symptoms, right? So far, these techniques work really, really great when you look at an animal study like mice studies. They do. You give it to them and they clear that amyloid out. It's very effective. The issue with humans is that it does that, often does that, but there's no change in the patient's quality of care of life. They still have a ton of memory impairment. So that's really been the holy grail here. I want to pull out just one form of this amyloid target, aducanumab, because it's been in the news. And so, again, this is an amyloid antibody geared towards amyloid. And last year, it was shut down. And then a few months later, Biogen turned around and applied for FDA approval for the drug that just got shut down. And this is unheard of. It caused a huge uproar in the field and a major swing in the stock market as well. And essentially what they've said is, well, we've had more time to look at the data, and in fact, patients who had a higher dose actually benefited. So we think we should be reconsidered for FDA approval. And so that's sort of the state of affairs with that particular drug. And we'll see what happens. The other target is tau, right? And tau, like amyloid, is kind of the new kid on the street, right? And it's very exciting. A lot of these, as you'll notice, don't have names yet. And we don't know a lot about how they're going to perform. There's one trial where it was trying to address a different disorder called progressive supranuclear palsy, and that was shut down, but it's still ongoing for Alzheimer's disease. So a lot of potential promise here. And I want to pull out one of these agents here too, as an example, just really to kind of highlight how this can be confusing for everyone really, even in the field, but very confusing for the public. So this particular agent, LMTM, was being studied in a very, multiple countries were involved, and everyone was very much looking forward to this study reporting. This is how it was reported in the science, okay? it didn't work, period. Okay, that was the brief that we got. This is how it was reported in the media. Okay, so hopefully you can see this is clearly mixed messaging and how this would be confusing. And essentially where this comes from is what I mentioned earlier, where a drug may cause a change in the brain that we want, but it doesn't translate to the disease process itself. The patient still is very impaired. And so that's what they were reporting, is it halted Alzheimer's disease, but they weren't really reporting that it didn't work. And so that clearly can be confusing. Just briefly, I want to highlight a couple of things. So in addition to amyloid, in addition to tau, there's lots of other interesting areas being looked at. For example, diabetes medication. This medication here is for IBS. So there's been some links with the microbiome and dementia. And so these trials we're following to see, do these ideas have any validity? You know, if we address Alzheimer's in a totally different route than amyloid and tau, are we going to get somewhere? One example to pull out here is oligomenate. This one I chose because it is making news just in the last few months, the end of last year, because it is the first drug to be approved anywhere in the world since 2003. And it was approved by our Chinese equivalent of the FDA. I'm not going to go into a ton of detail, except to just let you know that this is a medication that is derived from seaweed, and it's thought to basically stop a certain bacteria in our gut that inflames the brain, right? So interestingly, it has been approved in China even before the study has been published. So it would not at all meet criteria for our FDA. And I'd say overall the view of this in the field is one of cautious optimism, skepticism, but we'll see what happens. And I just want to note, of course, for those of us who work with or treat patients who are further along in the dementia process, that there are still a lot of work going on to look at things like dementia-related psychosis and agitation. Those are also in active investigation. Okay, so we do have some modern day snake oil to touch on. In the field, there's always one fad or another that gets featured, and then we get questions about it in clinic, you know, from year to year. At the moment, this is Prevagen, which I don't know if y'all have heard of. You can mention in the chat if this is something you're familiar with. But this is a over-the-counter supplement that comes from a protein in jellyfish, right? Makes them glow. It's the jellyfish vitamin, as patients will ask about. And it made a ton of claims. It's fairly expensive, and it's essentially a fraud. It has no scientific support, and the company grossly misrepresented it. And they just this year lost in court from a fraud lawsuit, and it's going to be probably one of the largest class action settlements that has ever occurred, with tens of $millions being awarded in damages. So in addition to the good science, there's always something else that we have to kind of regulate or think about with our care. Okay, so in summary, the trends here, okay. Last year, the FDA as a whole, not just in dementia, right? The entire FDA approved 53 new medications. 12 of those were in the vein of psychiatry and neurology. Exactly 0 of those, as you may have guessed, were for any form of dementia. This is obviously not the direction we want to be going. But I would say now, when we take a look back in 2020 at the last 5 years, we're seeing more diversity in the targets, which is very good. We're seeing greater, more creative use of medications that are already available to us. I didn't talk about BACE inhibitors, but that's an entirely different treatment target that has been entirely abandoned as of this year because of toxicity. And the other big trend is that research studies are involving more and more participants who are at the mild end of things. And that, again, it can only be a good thing. Okay, so I want to just shift and wrap up with talking about, again, this situation we all find ourselves in, which is COVID. And what do we know at this point? How does this potentially overlay or affect those of us in the dementia world? So this is data from the CDC showing essentially weekly deaths, all right? So typically, how many weekly deaths are there by month, in any given month, from dementia or with dementia on the death certificate. And you can see in the spring, there was a big uptick in the number of weekly deaths with dementia, of course, around the time of the spike here. In addition to that, this of course happened in multiple areas, right? It wasn't just dementia. Patients with respiratory disease, heart disease, we're seeing a big spike in their deaths too, obviously. But the problem here, which hopefully you can see here, is that everyone sort of spiked in the spring. The deaths went way up, but heart disease is back where it used to be. Respiratory disease is basically back where it used to be, but not here. It's still way higher than it normally should be in terms of weekly deaths, and it's not entirely clear. There are many reasons for that that are, in consideration. So there's no research to indicate that dementia itself increases risk for COVID, but the comorbidities that are very common with dementia, like COPD, et cetera, all those things certainly do. We do know that COVID can exacerbate a cognitive weakness, just like every flu season when we see dementia patients be worse off when they contract the flu. But specific COVID neurologic complications are being reported, and they're very interesting. Most of them, of course, are in case studies or series, but what is most commonly reported is some kind of stroke or an altered mental status. So whether that's encephalitis or psychosis, and that's interestingly happening more in the younger COVID patients. So really, when you look at the studies that are coming out really quickly related to COVID, you're seeing a case study here, a case study there, essentially across the entire nervous system. And we really don't know if there's a common mechanism for any of that. It's an obviously evolving situation. But some questions I think come out of it are, at the very beginning of our chat today, I showed you the projections, right? Will COVID significantly alter those projections, right? Of the kind of silver tsunami, right? How will our expectation of older adults alter significantly because of the pandemic? And will our expectation of the number of people who develop dementia change? That'll be interesting to see. And of course, the big unknown, which is if you have COVID now, does that have a long-term effect in relationship to dementia in any way? And of course, we don't know that at this point. Some challenges, of course, that we all have faced, and I'm sure you all know very intimately, are that COVID has impeded everything about dementia care, right? Staffing shortages, care centers closed, et cetera, and therefore patients are less safe, they're less connected, and that breeds problems in dementia. Also, what if your caregiver contracts COVID? Or what if you rely on an in-home healthcare provider and now you're worried about the safety of that? These are, important questions without easy answers. And then in addition, what are the effects of masks in our dementia patients, right? If you have more advanced dementia, masks can be very frightening. They can also kind of interfere with communication and make things harder to hear and comprehend, and that can increase confusion. What's the effect of the news, right? The kind of stress-inducing news binging that sometimes happens, and the disruption in routine. All of these things have the potential to accelerate stress levels, which we know already in dementia tends to accelerate the dementia process. So some practical considerations that these are things that we've been working with and thinking about in our center here. I'm sure you all have others to add, and I'd love to hear about them. But for example, the clear masks are something we've been using, as well as putting photos on our lapel or our shirt to help increase connection. The COVID precautions obviously need more, patients with dementia are going to need support and supervision with certain things anyway, naturally, but they need more support when it comes to COVID procedures. So there's a couple of things listed here for you. Do they need reminders to wash their hands, staying where they need to stay away from other people, that sort of thing. In the clinic, one thing I've seen really frequently with my patients is forgetting or having trouble inhibiting that automatic urge to shake someone's hand, right? It's very harder for patients with dementia to stop themselves from doing that or to understand why they're not allowed to do that. So recommendations that we're giving are to modulate exposure to the news. This is probably something and advice that all of us could take a little bit, but we want people to be informed, but have a certain time in which they're exposed and then let it go until the next day. Anything that maintains connection, of course, all of us have gotten, this is a whole new area for all of our lives, is trying to stay connected during COVID. But we know that loneliness and isolation tends to increase dementia symptoms. It increases agitation and so forth, and contributes to a faster decline. So those FaceTime calls with grandkids, et cetera, need additional support and really big area of emphasis. As does, of course, advanced planning, which is always, should be front of mind, but particularly in a pandemic with patients with dementia, we ought to be making sure that they have their ducks in a row in this kind of situation. So with that, I will stop and say thank you for having me. And in the vein of COVID, I'm certainly wishing all of us good health and a better year ahead. And I'm happy to take any questions in the time we have left.
We do have some questions here. The first question is, does Medicare pay for the amyloid scan?
The answer to that is it depends. So if it is ordered, it has to have a clinical rationale or reason why the amyloid scan is being ordered, and then it will be more likely to pay for it. So if someone is very young, let's say they're in their 50s, they're more likely to get that paid for by insurance than someone in their 80s, because the question is, why do you need an amyloid scan to know that it's Alzheimer's disease? So if it's not approved, you can pay out of pocket, but over time it's gotten better and better, and I expect that to continue.
Next question is, what is the role of inflammation in the most recent studies?
Right, so this is a great question. So the role of inflammation is complicated, but the general idea is that tons of diseases are related to inflammation, right? Atherosclerosis, which can lead to heart disease, and stroke has a lot to do with inflamed vasculature. So it's not a new concept. The idea is we have inflammation in our body, particularly in our gut, that bacteria can actually communicate with the brain. And that's kind of the going theory. So as I mentioned earlier, that seaweed drug that was approved in China, it targets inflammation in the gut. So there is a lot of interest in this area, and a whole very reputable set of literature that would argue that Alzheimer's disease has a heavy inflammatory underpinning.
The next question is, I have read a lot about the University of Pittsburgh AD clinic and the evaluation of cerebral spinal fluid. I understand they are seeing changes in CS fluid in patients in the 40s who have parents with AD. Can you comment?
Yeah, yes. So the CSF changes have been well documented, and essentially you can pull a little bit of spinal fluid out and test it for how much amyloid is in the CSF and how much tau is in the CSF. Now, really, you should have a decent amount of that in your spinal fluid. That's a sign that it's being cleared out of the brain, as it should be. And so if the ratio is off, it may mean not enough of it is getting cleared from the brain and making it to the rest of the CSF circulation, right? So that's how and why you're seeing it. Again, this is something that is more likely to be ordered when there's a lack of diagnostic clarity, or in cases where there's a heavy family history and we're trying to pursue clarity for that family.
Also,
I hope that answers your question.
Hopefully it does. Next question, how significant is alcohol consumption in the early onset of dementia?
Oh, great question. So alcohol is an interesting topic, a tricky one. Heavy alcohol use is a negative thing for the brain, right? It's a toxin for areas in the brain that are most vulnerable to Alzheimer's disease, like the hippocampus. So high alcohol use over a period of time, whether or not someone is quote unquote an alcoholic, right? They don't have to be an alcoholic, they just have to have high levels of intake. That increases the risk of dementia in some studies, whereas a small use of alcohol in many studies has been shown to be helpful for some people. Again, that's the general kind of rule of thumb.
Awesome, thank you so much. That's all the time we have for questions with Dr. Rossetti. So we thank you for your presentation today. It was very informative. I know that there are more questions. We encourage you all to try to interact with her via the chat, and we'll see if we can't get some answers to some of these other questions. So thank you so much, Dr. Rossetti. We really appreciate your talk today.
Thank you.
And thank you for being here.
Appreciate it. Thanks, everybody. Enjoy the conference.